Now, we have 15 minutes that separates us from lunch. We're at the end of our energy levels, maybe. But I would still like to give a few thoughts of myself and then open the floor, hopefully, for some questions and a bit of discussion. I would like to ask you for the questions. When you ask a question, to present yourself very briefly and to direct to the person you want to ask your question, or whether it's to the panel in general. Now, as a wrap-up, I hear there is lots of things happening in the field. There are activities, there are strategies, there is progress, and there are even people sitting together. There is dialogue and there's convergence. That's what we hear from these presentations. And that we also have the proper technology. It's still a bit weak. It still has some beginning errors, but the technology is there to provide us help, to provide us support to do this. But we've also heard from the first speaker that we are facing some major challenges in the quality of these data. Are they really representing the correct reality that we need to have, that we need to know? And does it guide us to use that information, the data that are available as per managers and decision makers? And I think that's where the main area of questions is situated. Now, thinking of the central theme of this conference, how does this evidence will help us to make better public health policies? Well, I have a question for myself. We know that policymakers, policy designers, once they've designed a policy or a regulation, have the tendency to consider their work as achieved. They've written the law, they've written the regulation, they send it out, and it will implement itself by itself. We know that's wrong, and we've seen findings, we've had findings in Vietnam, India, and China, we compared them, that this is really what's happening. What's missing is a good feedback loop. From these processes, we need to provide information, and that information needs to lead to action, and that's apparently where we still have major weaknesses in the information system from the different perspectives that has been presented. Now, so we need correct data. They have to represent realities that are the correct ones, and they need to lead to understandable messages for managers and also for policy makers, for decision makers. Now, I wanted to pick up something from a session, I think it was the opening session of yesterday. Somebody said, well, information is power. And that's very true. I believe strongly in that statement. So if we want to talk about users and not just beneficiaries of services, that means we have to inform users if we need to empower them. So my question also to the panel would be, how do we guarantee that civil society organizations are not dropping out of these processes of governance and regulation making, but also as being part and parcel of the evidence gathering that we are doing? That's something that I have for myself. If we consider policy making as a process of all of us, from the policy designers up to the users, then we all need to be receiving a share or a fair share of the information and a fair share of the power. That's what I would like to make as concluding remarks, and I would now like to open the floor to the public to raise your hands if you have any questions. I will take 3 questions, see what time we've got left, and then maybe have some more. I've got one here, one there, and one there.
I'm Juliet Nabionga from Uganda. My question goes to Dr. Sunda. The private sector seems to be lagging behind. What challenges are you facing getting them on board?
Yeah. Okay, I'll use this occasion to just start with a small apology. I've been giving such individual lectures that I didn't mention when I presented that I have actually 3 major co-authors, Pankaj Gupta and Amit Mishra, Alia Kausar and Nitisha Vasisht, who were part of that paper. A lot of the work was done by Pankaj Gupta that needs to have been mentioned there. Now, to your question as to the the private sector involvement. Some states are doing much better than others, like Kerala is. And there is a general reluctance, or there are three levels of problems. One level is, will private sector provide? And many of them have no motivation or incentive to provide and no compulsion to provide data. So that is becoming made part of a necessity under the Clinical Establishments Act. But that act is nowhere in complete implementation, so that's not being used. So that's one way of going forward, is to make it mandatory and give them a set. The second way is voluntarily ask them to report. Those who are under public-private partnership, especially for RCH, are reporting quite substantially, and that information, where it is quite widespread, is being collected very well. But again, there are many places which are not under a partnership, where some report, many do not report. The third is structural. At some point, the system of the software system is not so easy to keep on adding units, new reporting units into it. So it will want it predetermined. The DHIS2 system allows it. You can add on any number of, but most of the other systems want it predefined, or has to go back to the vendor to get the developer to design it. So you have in software, in private sector reporting, it will vary across. One way out of it that has been done is to merge that private sector data with the block level facility. But that really spoils your entire data use of management for facility management. It really spoils up. So there is therefore, at the level of technology, at the level of legality, at the level of process, problems. It's not so simple, and it's not likely to go away. That's why I said for policy users, we may still require to depend upon surveys rather than on this data. But some states have made very good progress on this. So it's
Okay, does that answer the question? Anybody from the panel that wants to add something on this? I think it's a very interesting and a key question on the involvement of the private sector. Nobody? Then we would go to the second question here.
Yeah, my question to Professor Sundaraman and probably Murli also. Why are we hesitant or averse, I don't know what is the right word, to ask the most fundamental questions in evaluation? Yesterday I had a presentation on effect of the institutional deliveries. What is the main purpose of institutional deliveries? What is the main purpose of conducting village health delivery? We are not asking this question, but asking nitty-gritties of how much check payment, how much this, but not the most fundamental questions. Evaluation doesn't make any sense whether institutional deliveries have delivered whatever it is to be done. Is the purpose of conducting the village health days, has it served the purpose? But we are not asking these two main fundamental questions.
And that's the question you want to ask to the panel members.
Why are we averse to do it?
Yeah.
Okay.
Well, there are evaluation questions and there are evaluation questions. There are evaluation questions that ask on the choice of strategy. When you say institutional delivery is a strategy, is that the right strategy, is one nature of evaluation questions. The other is, having taken that strategic choice, it assumes that there is a certain level of skills and facilities available and will reduce maternal mortality. So the second question would become, having taken institutional deliveries, is that contributing to decline in maternal mortality? That's another question on that. And of course, another level of question is, having taken institutional deliveries, is institutional deliveries happening? So, I mean, it's not quite fair to evaluate a program on an objective that it did not set itself. It's, I mean, evaluation, art of evaluation, the program evaluation should have, the basic design question is right. For example, a planning commission or the health policy at the senior most level will make a program as to, is this the correct choice of strategy? So I wouldn't place it either or, but I certainly agree with you that the basic fundamental questions upon choice of strategy do need to get fronted more. Sometimes we miss it, but you know, actually in this particular question, we've had quite a lot of people, the one on institution delivery, a lot of people have explored that.
Okay. You also wanted to...
Actually, Dr. Sundar has responded more or less what I wanted to say, but the first point I made, that it's always best to begin by assessing using the stated objectives itself. So if you go back to NRHM or even RCH, most of them would have used access, affordability and quality. So it's best to ask this question, has it led to improving access in terms of utilization of people, particularly from the lower economic groups, in terms of institutional care. The second is needs a very careful survey of affordability, which is related to the amount of money that they would have spent otherwise out of pocket had public system had not been beefed up by going to private system. I think that needs to be answered both in the latest POE Planning Commission report or even earlier studies. To what extent is NRHM actually reduced the out-of-pocket expense arising from institutional care of people who would have otherwise gone to private sector. And on the quality, I think normally we tend to, in a very indirect way, link MMR with the institutional care, but I think we need to go a little more at the criteria, performance criteria level, rather than the outcome level. Outcome is much more long-term impact. So I think you have rightly pointed out that we need to address that. That's what I was trying to indicate in my first slide. Yeah.
Okay, so it is agreed that apart from situation analysis, production of services and data, and outcome data, we also need impact data. And if we set a program without them, now we could say that the program is not well set. So I think that answers the question. There was a third question there in the middle.
Yeah. I'm Sukhwinder. I'm from Family Health International. So my question is on information technology systems, especially in human resources. So what we have seen during 2 days is whether it is HMIS or UHC, human resources is a very important part. So that means we need a human resource health management system as a management reform. So my question is, what could be the role of professional bodies, regulatory bodies or the councils in implementation of such information systems, especially in health, human resources?
Do you want to direct that question to anybody?
Anybody from the panel? I mean.
Who wants to answer?
Okay,
because we have many speakers from the information technology.
No, I agree. No, look, in human resources, there are many dimensions. The professional councils have a certain set of concerns. A public health manager has a certain set of concerns. And depending upon what actions are going to be taken, that concerns will get reflected. For professional councils, one of the fundamental problems of information today is this notion of maintaining a live register, which simply means that people register, but there is no way of going off the register. So whether you die or whether you retire or whether you leave the job or decide you will never do a day of nursing or doctoring again, you are perforce on the live register. So there has been this issue. And that would require some place where people can, if they want to deregister or be informed people that they are not in active practice, there is no provisions for it. So that is one set of issues. Program managers require it because of allocation of human resources according to requirements. And at some point, regulatory systems require it because they want to ensure that certain regulations are required. So I wouldn't see one system developing, I would see multiple systems developing, but you would save a lot of pain and effort if they have enforced standards of interoperability so that what one system has collected, the other one can take without having to collect that information all over again. But if you expect the government to do the council's job or the council to do the government job, they simply won't do it. I mean, they don't have the time, they don't have the money, they don't have the space, they won't even have the domain knowledge. So you would have to look at different systems and how they relate to each other.
Does that answer the question? It's now 12:29. We've got 1 minute more. I would give room for one burning question. Well, there is a burning question.
There are two burning questions, yeah. Yes. Rupa and from Kerala, she is the mission director.
It's a practical question from the state, because
could you present
Kerala,
yourself?
I'm Dr. M. Beena, I'm Mission Director for the state of Kerala. So our state is also one state where the JPHN herself does the data entry. We have not employed data entry operators. So my JPHN asked me, I do the MCTS data entry, I capture every pregnant woman in the MCTS, and again, the very same data I have to enter in the HMIS. The only thing is MCTS captures names and HMIS captures numbers. So can we not simply integrate the two so that MCTS becomes the primary data entry portal and HMIS can capture this? And number two is we also have a parallelism with the social welfare department. Social welfare department, the Anganwadi worker also presents almost similar kind of data. So at the end of the day, we give different portals, we give different platforms, and we are asked to reconcile. So will it not be a wiser option to integrate the data entry itself in the first place?
A very burning question indeed, too. Even we could say if the mission director for Karnataka State is asking questions about duplication of work, so what would policymakers think about this? Who wants to answer?
Let him go and then I... We have different answers. It's working.
Integrating MCTS and HMIS is a difficult thing, madam. The first thing is, HMIS is a facility-based reporting where what has happened in the facility will be reported. Earlier, Karnataka was also practicing area reporting, because what has happened in the area will be captured. It's a duplication actually, because if in a particular area, if a woman goes for sterilization, she will undergo sterilization in some taluk hospital. Taluk hospital also will register the sterilization, whereas in the sub-center, the ANM also will register the sterilization, saying that that lady belongs to our area. In facility, it is facility-wise. In MCTS, what happens? It is exactly the area reporting, because the managers or the taluk health officers or the district health officers wanted to know what is happening in their area. So MCTS generates the report based on the area. Whereas HMIS, if at all, if you want to very clearly demarcate, then software has to be developed in such a way that even if the particular patient takes services elsewhere, that report has to be generated for that facility. The second thing is, you said integration of health, WCD. Yes, many programs what we have done on MCTS, now already we have started. For example, Women and Child Development Department is utilizing our data for nutrition aspects. And we have also integrated it with the Directorate of Economics and Statistics for issuing the birth certificates. All these three departments already we have conducted training programs for the district level officers, totally 90 officers, integrating the same MCTS portal to make use of issuing the birth certificates or monitoring their respective programs. Thank you.
A very short
I have
addition.
a sort of alternative to suggest. I think HMIS system should have a standard. The standard, one of the many standards that it should have is, each service provider should enter that particular data only once onto a screen, and then it is up for the computers to give it to whosoever user of the data is. If that principle is followed, it's just not on that they will enter it separately in MCTS and HMIS. As his problem has been, because in some sense, by adjusting ourselves to the software, we also start adjusting the way we think about software. One of the things that we could do is area and service reporting is not at all difficult, because all you need to do is to mark whether the service was provided by you or was provided by others, which will automatically be, then the computer sorts it out and generates the numbers that go on to HMIS. Fundamentally, because we let this decision be taken over by vendors and people who have not understood, and this networking that we need between IT, public health and sheer common sense is so missing within our system that we make such huge blunders. It's a blunder which has been very costly for the system. I think we have to somewhere get away from that. So there is an effort on now to integrate the HMIS with so let's wish it all the best. It starts tomorrow, day after. Amit is attending the first meeting of that. So we are looking at standards and interoperability.
So I understand you are responsible of repairing the blunder.
Yes, yes, I wish I could be made responsible, then I would do it, but at some point, yes, we are working at that. I think they have now seized of the fact that it was a design issue. But you see the problem, when this is the problem, UHC, the brave new world of UHC is expecting to capture every illness happening everywhere, in every place, and then relate it to the individual and be able to track care. And we're just not managing to sort out the institutional delivery happening in the CHC from the sub-center. And that's the sort of gap. I think our minister understood it very well and explained it in rather great detail to the Prime Minister and the Planning Commission, but I'm not sure they understood it. Yeah.
Well, we really have to end here. It's a very interesting discussion. On the note of the use of information being not for policing workforces, but for to assess performance, we could give back the message to universal healthcare strategic people that the information system nationwide and at the level of the state still faces a lot of challenges that would need to be dealt with before. I want to thank each and every one of the presenters for a very interesting session indeed. And I'll hand over back to my Master of Ceremony, my Masters of Ceremony. Thank you.